Imagine two people walk into the same emergency room on the same night with the same broken arm. They both have health insurance. One walks out owing $800. The other gets a bill for $14,000. Same injury. Same hospital. The difference is buried in the details of their insurance plans, details that most Americans never read and that no one ever clearly explains. More than half of U.S. adults say they don't understand basic health insurance terms, and that confusion costs real money. Roughly 1 in 5 insurance claims gets denied, often for reasons the patient could have prevented. This is how health insurance actually works, from the first dollar to the last, explained in plain English. Health insurance is a system for splitting costs between you and an insurance company. The split changes as you spend more money in a single year, moving through 4 stages. Stage 1 is the premium. This is your monthly payment just to have insurance, whether or not you use it. In 2026, the average benchmark plan costs around $750 a month before subsidies. Most people pay far less because government tax credits cover a large portion of that cost. Stage 2 is the deductible. This is the amount you pay out of pocket before insurance starts contributing. If your deductible is $2,000, you pay the first $2,000 of your medical bills yourself each year. Preventive care, annual checkups, vaccinations, screenings is exempt. Insurance covers those from day 1. Stage 3 is coinsurance and copays. Once you clear the deductible, you and the insurer share costs. A copay is a flat fee. Say $30 for a doctor visit. Coinsurance is a percentage split. You might pay 20%, and insurance pays 80%. Stage 4 is the out-of-pocket maximum. In 2026, this cap is $10,600 for an individual plan. Once your total spending on deductibles, copays, and coinsurance hits that number, insurance covers 100% of everything else for the rest of the year. This is the ceiling. It exists in every ACA-compliant plan. These 4 stages are the entire financial architecture of health insurance. Everything else, plan types, networks, enrollment rules, is built around this structure. Health insurance plans come in 4 main types, and the differences are simpler than the acronyms suggest. There are really only 2 questions. Can you see any doctor you want, and do you need permission first? An HMO, Health Maintenance Organization, is the most restrictive. You pick a primary care doctor, and that doctor refers you to specialists. If you go outside the network, you pay the entire bill yourself. The trade-off is lower premiums. A PPO, Preferred Provider Organization, gives you the most freedom. No referrals needed. You can see any doctor, in-network or out-of-network. Out-of-network just costs more, maybe 30 or 50% coinsurance instead of 20. Premiums are higher. An EPO is the middle ground. Like a PPO, you don't need referrals to see specialists. But like an HMO, there is zero coverage outside the network. No exceptions except emergencies. An HDHP, High Deductible Health Plan, isn't really a network structure. It's a cost structure. The deductible is higher, at least $1,700 for an individual in 2026, but the plan qualifies you for a health savings account, which has significant tax advantages. We'll come back to that. The plan you choose determines how much flexibility you have and how much you pay for it. There is no universally best plan. It depends on how often you use healthcare, whether you have preferred doctors, and how much financial risk you're willing to absorb up front. Under the Affordable Care Act, insurers are prohibited from charging you more based on your medical history, gender, or pre-existing conditions. Those protections are federal law. Only 4 factors can legally affect your premium. First, age. Insurers can charge older enrollees up to 3 times what they charge younger ones for the identical plan. A 64-year-old pays roughly triple what a 21-year-old pays. Second, location. Premiums vary by county because healthcare costs vary by region. A silver plan in Vermont might cost $1,200 a month, while the same tier in Maryland costs under $500. Third, tobacco use. Insurers can add a surcharge of up to 50% for tobacco users. This surcharge is usually not covered by government subsidies. Fourth, plan tier. Bronze plans cover about 60% of expected costs and have the lowest premiums. Silver covers 70%. Gold covers 80. Platinum covers 90. Higher coverage means higher premiums. You're trading monthly cost for lower out-of-pocket risk. That's it. 4 factors. Everything else is off limits. The claims process is where most confusion and most surprise bills originate. Here's what happens behind the scenes every time you use healthcare. At the point of service, the provider checks your insurance eligibility and collects your copay. After the visit, the real work begins. Your encounter gets translated into medical codes. CPT codes describe what was done. A standard office visit, an X-ray, a blood panel. ICD-10 codes describe why it was done, the diagnosis. If the procedure code doesn't match a valid diagnosis, the claim gets denied. This is called a medical necessity denial, and it's one of the most common reasons claims fail. The coded claim is submitted to your insurer. Their systems check it against your benefits. Are you eligible? Is the provider in network? Was prior authorization required? Does the procedure match the diagnosis? This is called adjudication. The insurer then sends you an explanation of benefits, an EOB. This is not a bill. It's a summary showing what the provider charged, what the insurer's negotiated rate was, and what your share of the cost is. The actual bill comes later from the provider. In 2026, approximately 1 in 5 in-network claims on the ACA marketplace are denied. The most common reasons are administrative, missing information, coding errors, lack of prior authorization. And fewer than 1% of denied claims are ever appealed by patients. The system relies on most people accepting the denial without question. There are 4 main paths to health insurance in the United States. The most common is employer-sponsored insurance. Your employer selects a set of plans, and you choose during an annual enrollment period, typically in the fall. Premiums are deducted pre-tax from your paycheck, and most employers cover a portion of the cost. The second path is the ACA marketplace, healthcare.gov or your state exchange. Open enrollment for 2026 coverage ran from November 1st, 2025 through January 15th, 2026. Outside of this window, you can only enroll if you qualify for a special enrollment period, triggered by events like losing other coverage, getting married, or having a child. Third, Medicaid provides coverage for low-income individuals and families. Eligibility is based on income, and you can enroll year-round. Fourth, Medicare covers Americans 65 and older. There's a specific enrollment window around your 65th birthday, plus an annual open enrollment from October 15th through December 7th to switch between plans. If employer coverage costs more than about 10% of your household income, you may qualify for marketplace subsidies instead, even if your employer offers a plan. 2 types of accounts let you pay for medical expenses with pre-tax dollars: health savings accounts and flexible spending accounts. They sound similar but work very differently. An HSA requires a high-deductible health plan. In 2026, you can contribute up to $4,400 individually or $8,750 for a family. The money rolls over indefinitely. It never expires. It's yours even if you change jobs. After 65, you can withdraw it for any purpose, taxed like a traditional retirement account. An HSA is one of the most tax-efficient savings vehicles in the U.S. tax code. An FSA is offered through employers and doesn't require a specific plan type. The 2026 limit is $3,400. The critical difference: FSA funds mostly expire at the end of the year. Only $600 to $80 can carry over. If you don't spend it, you lose it. For people with predictable medical expenses, an FSA provides immediate tax savings. For people who want long-term flexibility and portability, an HSA is significantly more powerful, but it requires accepting a higher deductible up front. There are specific points in the system designed to be misunderstood, or at least not designed to be understood. Trap 1. The out-of-pocket maximum has limits. It only applies to covered in-network services. If you accidentally see an out-of-network provider or receive a service your insurer deems not medically necessary, those costs are not counted toward your cap. You can exceed the maximum. Trap 2. Not all high-deductible plans qualify for an HSA. The plan must meet specific IRS thresholds and cannot offer any benefits before the deductible except preventive care. A plan with a $2,000 deductible that offers $30 copays before the deductible is not HSA eligible, even though it has a high deductible. Trap 3. In-network doesn't always mean the same price. Many PPO plans now use tiered networks. Tier 1 preferred providers might have 10% coinsurance, while Tier 2 participating providers have 30%. Both are technically in-network. Trap 4. The appeal system exists, but almost no one uses it. When your claim is denied, you have the right to appeal. First to the insurer, then to an independent external reviewer. The data shows that outcomes for patients who appeal are significantly better than for those who accept the denial. But fewer than 1% ever file an appeal. The process is deliberately opaque, and most people assume a denial is final. So why did one person pay $800 and the other pay $14,000 for the same broken arm? Person A has a gold PPO plan. The hospital is in network. They've already met their $1,000 deductible earlier in the year. Their coinsurance is 20% on a negotiated rate of $4,000. They owe $800. Person B has a bronze HMO plan. They haven't used any healthcare this year. Their deductible is $6,000. The hospital happens to be out of their HMO network. Because HMOs offer zero out-of-network coverage, insurance pays nothing. Person B owes the full chargemaster rate, $14,000. And none of it counts toward their out-of-pocket maximum. Same night, same arm, same hospital. Completely different financial outcomes, determined entirely by the details on page 47 of their policy documents. Health insurance isn't complicated because it has to be. It's complicated because the details are buried in plan documents, in billing codes, in denial letters most people never read. That's what this channel is about. We read the fine print, so you don't have to. If this helped, subscribe. There's a lot more to explain.